Okay.
Okay, so this is the 2021 November SurgPath exam. The first question was Dr. Hussein, so we'll just get right to it. The patient is a 39-year-old male. I'll give the stats at the end so we can just get going. The patient is a 39-year-old male status post lung transplant undergoing resection of transplanted lung for retransplantation. I will just like to emphasize that clinical. What is your differential diagnosis / favorite diagnosis? So this is the cut section of the lung. Remember, this is already a transplant. This is not the patient's native lung. And this is the histology.
Okay. So thanks, Nicole. That was the most important part of the history that I think people need to remember. Anytime you're taking any exam, make sure that you read the stem or whatever the history is given very carefully, because your interpretation in this case was obviously dependent on the fact knowing that the patient is a retransplant and this is the explanted transplant lung. So when you look at it, there was grossly, there are areas of fibrosis and irregularity. I mean, some of the cuts are not quite, they don't quite show that defect in the middle is not right. But the piece of the lung that's all the way to the right, it looks pretty good, except outline-wise. I mean, it's complete, but the surface is irregular in some areas of fibrosis, because that's about all it shows. And the microscopic examination, however, shows you changes both in the artery and the airways. So you do need to find airways and arteries that go together. And you can look at like, oh yeah, this one coming up right at the top, right there. So you see like this blood vessel is very fibrosed with marked intimal fibrosis and a very small lumen. So in this context of a lung transplant, this could be, this is most likely chronic vascular rejection, which gives you intimal fibrosis. Most of the times, the vascular rejection is not this prominent as in this patient, whereas the more obvious chronic rejection is like that little airway that was right next to the, where you were just, yeah, right here, under that one. So the second main finding here is that of what we call bronchiolitis obliterans, which is fibrosis under, yeah, that one, fibrosis in the submucosa. So that is what actually leads to the patient's symptoms more often. So chronic rejection is more commonly bronchiolitis obliterans, and it starts as a submucosal fibrosing process, and it can be patchy, it can be involving only part of the airway, or like here, it can be a mild, diffuse, mild fibrosis right underneath the epithelium. What else? So you can have concurrent acute rejection, which this one doesn't have, but and often the interstitium may be normal, or there may be some air trapping, or you can get fibrosis in addition in chronic rejection. But the two together, having the vascular change and the airway change, makes me think that this is chronic rejection. The other differential would be recurrent thromboemboli, because these patients are not the walking about as much. I mean, they may be more likely to have been in extended times bedridden, especially post-transplant. You would think in your differential, when there are that many vascular changes, could it be thromboemboli? But it is so circumferential and no recanalization. That's what it looks like. Okay. Cool. So those two findings. Yes.
Thank you. I think, there was some concern in the incorrect comments for UIP, maybe because of this impression of some airway changes with fibrosis, kind of maybe in this area, maybe.
Yes, there is some areas of fibrosis because of the vascular involvement. It gives you, anoxia in that area. So in UIP, the main finding to look for is that variation in intensity, which this does have. You have some areas that are less involved, other areas that are more involved by fibrosis. But within those areas of fibrosis, you should have fibroblastic foci. You cannot make a diagnosis of UIP without fibroblastic foci. And the second thing is that it doesn't recur in the transplant lung. So if you looked at the history, so morphologically this doesn't fit, and history it doesn't fit. Okay. The only disease that recurs in the transplanted lung is sarcoidosis.
Oh, interesting.
None of the other diseases recur.
Okay, thank you. Does anybody have questions on that case? All right, let me go to your next one. Which I think was this one. Yep.
Yes.
37-day-old deceased male. His mother suffered from preterm premature rupture of membranes. The infant suffered respiratory distress followed by necrotizing enterocolitis, sepsis, and death. What is the organ and what is the diagnosis?
Okay, so I think everybody should have been able to recognize that this is the thymus. You recognize it by the fact that it is lobulated structure, very blue. And then when you go closer in, there are both epithelial cells, which are the thymocytes, and lymphocytes, as well as some Hassel's corpuscles, I think are somewhere. Yeah, like in that upper one. Right. So the organ, so what you should, at low power, what you need to look at is that these are really far apart lobules, and the lobules are small. Maybe you won't have an assessment for how small they are because you need to have a mental image of what normal looks like. But if you remember that normal thymus is like a jigsaw puzzle, and it fits together with only a few strands of fibrous tissue making the lobules, not like these large areas of connective tissue between the lobules. So that already makes you think that this is an abnormal thymus. So what is the abnormality? First, in a child, you do think of congenital thymic dysplasias or aplasias or those things, but the history of so first of all, the architecture is pretty normal. The relationship of the cortex to the medulla is normal. The medulla is the one that has the Hassel's corpuscles. And the Hassel's corpuscles are also normal. In thymic dysplasias and in immune disorders or deficiencies of the thymus, the Hassel's corpuscles are markedly abnormal. Many of them are cystically dilated. They can become calcified, and even in this age. And so that is what would lead me to think of that, of a congenital thymic dysplasia rather than just involution, which is this. So how do you know that this is acute thymic involution? First, it's the history. It's a premature baby with necrotizing enterocolitis and whatever that led to the death, and sepsis that led to his death. So that time period of, it only needs about a day or two of stress to start stressing out, start seeing the changes in the thymus. The first change is mobilization of the thymocytes, of the lymphocytes, leaving back a starry sky appearance. Second is when the cortex gets thinner. Then the third is when like this one, when the cortex appears almost paler than the medulla. And then the stage 4, so these are 4 stages, stage 1, 2, 3, 4. Stage 4 is when almost all the lymphocytes are gone. So this, I would say, is probably about stage 3, which generally correlates to about at least 5 days of stress. So why do we think of the thymus, the acute involution, and stage it? Because it correlates with the duration of the stress. It is not that important in a child that's already born and then lives for a while. But if it was, say, a stillbirth or a perinatal death, and there are thymic changes going back to, say, 5 days or whatever, 7 days, then you would say, oh, in utero, the baby was stressed. And so there were maternal fetal issues leading to any kinds of stress. It could be sepsis, it can be just prematurity can do it, necrotizing enterocolitis, all of the things that happen, anemia, or anything, congenital malformations, that they are born, not while they're in utero, but after they're born and they undergo surgery, all of that can lead to acute thymic involution.
Awesome, thank you. Any other questions? All right, so does anybody else need to go or would like to go next from the faculty side?
I can go.
Okay. Let me take you to, okay, where was yours? Up here. Do you want a screen control?
Yes, please.
Okay. Oops.
Okay, so this was a 56-year-old female with a uterine mass. So here we have the gross image of the uterus. And as I tell you guys, you can go ahead and cut it in half. It's not going to hurt the specimen after you have already bivalved and inked and bivalved it. So you can see the large mass within the, basically occupying the entire endometrial cavity. A higher power view of that. Then you can see that there is some invasion in the gross specimen. And here is our mass. So this one, we go in higher power. You can see we have these back-to-back glands. Some cribriform architecture is also present. So we go in higher power. You can see we do have some mucin in the lumens of the epithelium. So there is some mucinous differentiation in this tumor. And the nuclei, they're pretty open chromatin. Nucleoli are not that prominent. So as we're looking at this, we're thinking based on the architecture, we think of an endometrioid carcinoma. And then looking at the nuclear features, just to make sure it's not a high serous that's mimicking an endometrioid, we can see that the atypia is not as pronounced as we would expect for a serous, and the mitotic activity isn't that high either. So this is definitely an endometrioid carcinoma with mucinous differentiation. In the recent WHO, they actually got rid of the mucinous carcinoma of the endometrium because most of these are just endometrioid carcinoma with mucinous differentiation. And yeah, so then we grade endometrioid carcinomas based on the amount of solid growth. So this one we can see is all, sorry, one second, someone just came in, is all glandular. So that would be a endometrioid carcinoma FIGO grade 1. And if it's between 5 and 50% solid growth, we call it a grade 2, and greater than 50, we call it a grade 3. You can up it based on nuclear the amount of nuclear atypia, but the it should really be a grade 1 endometrioid with grade 3 nuclear atypia, and that is extremely uncommon, and you really want to make sure you're not missing a serous carcinoma. So the first question was just, what is the diagnosis? So the diagnosis is endometrioid carcinoma FIGO grade 1. And then we zoom out a little bit. You can see we do have some invasion into the myometrium here. And we can tell it's invasion, not an irregular endomyometrial junction, because you can see this inflammatory response and some desmoplasia around the tumor. So the second question was, what is the type of myometrial invasion? And this is actually the microcystic, elongated, and fragmented, or MELF pattern of invasion. And we call it that because you can see they're forming these little cysts. They're like microcysts, and they're very elongated, and it's almost kind of looking like a fragmented tumor here. They tend to have a lot of inflammation around it, especially acute inflammation. So that's a thing to pick up if you're scanning on low power and you see a lot of inflammation in the myometrium. You should go on higher power to make sure you're not missing a minor focus of myometrial invasion. And the last question was, what is this affiliated or associated with? And MELF pattern of invasion is associated with an increased risk of lymphovascular invasion and hence lymph node metastases. So we want to look carefully at the vessels when we see this to make sure we don't see any tumor invading into the vessels, and then careful examination of the lymph node too. And this patient actually had isolated tumor cells on her lymph node metastasis. Any questions?
Awesome, thank you. Let me just check the chat. Okay. Awesome, thank you. Let me just see the chat. Could we please repeat the question? Yeah, Yeah, we did. We have been repeating the question. I'm not, you may have just missed it. They're all embedded in the slides. Okay, which pathologist, thanks, Jenny, which pathologist would like to go next? And by the way, thank you so much for saying that about cutting the fundus. Yeah, because by not cutting through that, you're sort of missing like a few centimeters of tissue here that you could evaluate. So awesome. Okay. Next.
I can go next if you want me.
Sure. So let me see. That's not you. That's not you. That's you. Do you want screen control?
Yes, please.
Okay.
Okay. This was a 56-year-old male with a prostatic polyp that underwent transurethral resection of the polyp. And the question was, what is your differential diagnosis and paper diagnosis? Now, when they say prostatic polyp, the lesions that could be polypoid, pedunculated, they usually tell you also what is the surface. And in this case, the polyp or the lesion had a smooth surface. And that's very useful in this kind of lesions to know. Now we have multiple fragments of tissue. Is this not, I cannot focus. Nicole? Hello? I cannot go any higher.
Yeah, hold on a second. I needed to unmute. Yeah, because this is just the question. Go to the next slide.
Oh,
There.
I'm sorry.
It's okay.
I didn't realize that. Okay, as you can see, there are multiple fragments of tissue that look very similar. And when you start looking from, let's say, this end, you can actually see that there is a surface that is pretty attenuated. And when you go down to this area, you notice that the cytologic feature of the surface urothelium is very bland. There are no mitotic activity, there is no hyperplasia, there is no nuclear atypia, mitotic figures I already mentioned. The lesion itself very much imitate the surface features, except that is underneath. It's in the lamina propria. And when you look at all the tissue, all this epithelium, it seems to be somehow corded. It's in cords, but all cords have very similar thickness. Another thing that is interesting is that usually when you have papillary lesion, the vessel with the stroma is in the middle and the epithelium is around. In here, actually, epithelium is in the middle and the stroma is around. As I said, all cords look very similar thickness. And in some areas, you can see actually small cystic changes and this pink material that they sometimes call colloid cysts. In addition, if I can find this, because it's really hard to, you can have a small, this is not maybe the best. You can have small cystic areas that are lined by mucinous epithelium or a squamous epithelium, which actually represent squamous metaplasia. If you put all this together, you can diagnose inverted urothelial papilloma. These are benign lesions, and they account for less than 1% of all lesions of the urothelium. And the main thing is not to mistaken these for urothelial carcinomas. Now, differential diagnosis, of course, it's just regular papilloma, which is exophytic lesion that has very, very thin fibrovascular core and lining of urothelium that is absolutely perfect. It looks just like normal urothelium. The second is, of course, what we call PANLAP, which is again exophytic lesion with papillary architecture. And then, of course, low-grade papillary urothelial carcinoma. Now, I'm going to, again, talk about that on my next case, but I was trying to find this little areas of cystic change that have mucinous metaplasia. Sometimes they even have little bit of neuroendocrine differentiation, and I found one really cell with this nice pink granules, but of course now it's really hard for me to find this again. Anyway, very thin cords, no hyperplasia, very thin cords with the central epithelium, periphery is stroma, no mitotic activity, no necrosis, yeah. This is inverted papilloma. Any questions? No? Nicole, can I go to my next case? Okay, let me find the next case. Is it this one? Okay, my next case is a 76-year-old male undergoing transurethral resection of urinary bladder tumor. What is your favorite diagnosis? Now we are in a bladder as opposed to prostatic urethra. And again, we have multiple tissue fragments that, as we look at in here, have similar pattern as the other case that I previously mentioned. There are, again, cords of epithelium. However, the cords of epithelium are much thicker, as you can see, and they are variably thick. They are not all uniform. In addition, as I mentioned, the middle is actually fibrovascular core, and then epithelium is around. Again, fibrovascular core on both sides is epithelium. That's a difference, different from the previous case that I showed you, which is inverted papilloma. Now, this case also had some areas that had more of a prominent papillary growth, if I can find that, I'm sorry. Like exophytic papillary growth rather than just inverted growth of pattern of growth, where actually you can see that papillae are actually growing outward rather than inside the lamina propria. Now, for this one, diagnosis, differential diagnosis would be just regular papilloma versus PANLAP versus papillary urothelial carcinoma, low grade. And as I remember in this case, pretty much papilloma is out due to thickness of the epithelium. Papilloma, as I said, should have thin fibrovascular core with pretty much perfect urothelium around, which is not hyperplastic. Now, in this case, as far as I remember, there were also some mitotic activity behind what I would consider just PANLAP or papilloma, and therefore this would be consistent with papillary urothelial carcinoma, low grade. In this specific case, this is non-invasive lesion because you have very smooth outlines between epithelium and stroma. Therefore, this is papillary urothelial carcinoma, low-grade, non-invasive. As you know, by even if you have very, very bland tumor, if it's invasive, we would call it high-grade. Now, since I described morphology and differential diagnosis, I just want to mention there are multiple papers, but recently a really good one where they sequence inverted papillomas and low-grade urothelial carcinomas with inverted growth patterns similar to this. And they have very distinct molecular signatures. The inverted papilloma is enriched in HRAS and KRAS and does not have usual mutations that carcinomas have, which is mostly FGFR3, TERT, P53, and so on and so on. And therefore, they were able to prove that these entities are entirely different. And therefore, if you have any doubts, you can actually sequence these and figure out what they are. Now, to remember that inverted papillomas and papillomas are entirely benign lesions. In the past, there were reports that they recur and whatever, but this is probably due to sample selecting, which probably wasn't entirely perfect. Therefore, remember, inverted papilloma are entirely benign. They're enriched in KRAS and HRAS, and papillary urothelial carcinoma, low grade, even PANLAT, they have specific mutation, most commonly FGFR3, TERT, and P53. Any questions?
Tatiana, can I ask one?
Mm-hmm.
What did you say about that grading? I missed it. That any transitional or urothelial carcinoma that invades is high grade?
Yes, by consensus. In Europe, the grading, they still grade invasive urothelial carcinomas into low grade, high grade. In United States, by consensus, there's a paper published a few years ago. If you have invasive tumor, no matter how it looks like, you call it high grade.
And invasion could be just in the submucosa, not muscle invasive.
It could be any invasion, then it's a high grade.
Oh, wow. I learned something new. Thank you.
Yeah.
But Dr. Antish, not all high grade are invasive.
Of course, that's why we say papillary urothelial carcinoma, low grade, non-invasive, papillary urothelial carcinoma, high grade, non-invasive. I mean, that's why we actually clarified this from get-go. Now, for high grade non-invasive, they will still go and give usually BCG, despite non-invasive. But for low grade, some urologists don't do that. It depends.
Thank you. That was very helpful clarification. I'm glad you brought up that point because I did not realize that you still grade the non-invasive. Okay.
Yeah, I mean, this is not a rule. If you look at WHO still mentioned that you can grade invasive urothelial carcinoma, but there's paper which was consensus in the United States that all urologists decided that pathologists and urologists decided whatever is invasive should be high grade. It's not like you have to, but it's consensus.
Thank you. There was a few comments on the exam about muscle. So I assume this is muscularis mucosae. And so can you comment on the importance of mucosae versus sort of propria or whatever in the?
We do always mention, and it's a quality point for our urologists. because we want them to know how deep they excise the lesion. And that's why we always say muscularis propria present or muscularis propria not present. Yeah.
Okay.
That's for them, for their own quality purposes. Now, also, if you don't have muscularis propria in your specimen and you have invasive tumor, they have to go back and redo excision because there could be invasion into muscularis propria that they didn't sample. Therefore, point of muscularis propria is very important. Now, the problem between muscularis mucosae and muscularis propria is only when the tumor is invasive and you have smooth muscle in between tumor. Is it muscularis mucosae or is it muscularis propria? Useful things are that if you see lots of vessels, usually that's where, that's a lamina propria, obviously, and then it's muscularis mucosae. But if you do not see in that layer prominent vessels, then the issue becomes, is it muscularis mucosae or muscularis propria? Sometimes it's just impossible to say. And I know that people use smoothline. In my opinion, it's a useless stain. But what I usually do, I just say that tumor is invading into smooth muscle fibers. And I say that I'm uncertain if this is muscularis mucosae or muscularis propria. Now, there are studies that would like to actually separate invasion into lamina propria, which is T1A, versus T1B, which is muscularis mucosae, because they say that prognosis is worse if you have even muscularis mucosae invasion. Therefore, this whole issue of smooth muscle is very important in bladder resections.
Great. Thanks. Any other questions? All right. Anna or Lindsay, would you like to go?
I can go.
Sure, I can. Oh, okay, go ahead.
Okay, thank you.
All right. I think this is, you want control?
Yes.
Okay.
Let me see. Okay, how to make it bigger?
Just read the question from here and then go to the next slide.
Okay. Okay, so yeah, the history was 71-year-old patient with breast mass. And what's your differential diagnosis or favored diagnosis? I lied in the history because this is a slide from the autopsy case that Kyle brought me one day, and I thought it was, I couldn't figure out actually what this is at the first sight. So I saw this definitely tumor composed of epithelial nests embedded in the thick fibrotic stroma. When I went higher power, you know, I saw that they are fairly circumscribed. The distribution is haphazard, sometimes referred to as jigsaw puzzle. When I went higher, I started to recognize that there are fibrovascular cores, so papillae. They are pretty delicate, I would say, not like a thick papilla as you see in intraductal papilloma. And then when I went closer, I realized that there is something odd about the epithelium lining the fibrovascular core. So normally in the nucleus is located at the basal portion of the cytoplasm. So it's close to the fibrovascular core. In this case, you see that the nuclei are located at the periphery, at the apical portion of the cell. Okay, so the diagnosis in this case was tall cell carcinoma with reverse polarity. It's also called solid papillary carcinoma with reverse polarity, but current edition of WHO recommends tall cell carcinoma with reverse polarity, and it's a very rare subtype of invasive breast cancer that is associated with IDH2 hotspot mutation. I'm trying to find another feature, but this case doesn't have it prominent. So some cases have very nice histiocytes within the fibrovascular core, but here I cannot really see. But the key features is this reverse polarity. And so these tumors are rare. They present as mammographic or palpable masses. Ultrasounds show well circumscribed tumors. And on microscopy, as we already said, there is a solid papillary tumor. The tumor cells are tall, columnar, and cytoplasm is abundant. The nuclear features are bland. Some of the nuclei actually may show some grooves. I think you may see some grooves and intra-cytoplasmic inclusions. But the striking histologic features is the reverse polarity. And although there is a histologic similarity to thyroid carcinoma, tall cell variant of thyroid carcinoma, the immuno and molecular studies confirm the breast origin of this tumor. So most of these tumors are triple negative. Sometimes you may see weak focal staining for ER or PR. Almost all cases are negative for HER2. Ki, as you would expect, is very low. It's a rather low-grade neoplasm. Interestingly, these tumors express both low molecular weight keratins such as CK7 or CAM52, as well as high-grade cytokeratin CK56, for example. Chromogranin and synaptophysin that you can see in solid papillary carcinoma, like the normal one in the breast, are negative in this tumor. Myoepithelial markers, I think, should be used in every case, and they are absent around those nests, but also are absent in the fibrovascular core. So like that negative staining we should see. Some studies show that this tumor is positive for calretinin, but honestly, I don't know much about that. And breast markers like GCDFP or GATA3 or mammoglobin show variable staining, but in generally one of them should be positive. However, TTF1 and thyroglobulin are consistently negative. Yeah, so this case should be staged according to last edition as a type of invasive breast carcinoma and has indolent prognosis, indolent course and favorable prognosis. It would be all. I think it's very cute, this arrangement.
Very picturesque. Thank you.
Yeah, thank you.
What a finding on an autopsy. Very cool.
Yeah.
And the
So
histology is so well preserved too.
very well preserved histology, and we the autopsy team didn't find any metastasis, and great job that they palpated her breasts and they
Wow.
discovered this nodule.
Great. And did they sampled axillary nodes? Is that what happened then?
This I don't know if this
Or at least palpated the axillary nodes?
Yeah.
Perhaps. Okay. Cool. Any questions?
I have questions. So Dr. Bernacca, is solid papillary carcinoma is the same of tall cell carcinoma with reverse polarity? They are the same?
No, they're not the same. This is like, it resembles a solid papillary carcinoma. However, it's a distinct entity. It's a different entity. However, we spoke with Nicole that because this is a very rather unusual and rare breast tumor, we will accept the diagnosis. We will get some credit for solid papillary carcinoma as well as for papillary carcinoma.
Okay, thank you.
Awesome. Thank you. Yeah, as was mentioned, if you said some kind of carcinoma, you got at least partial credit. But if you said papillary, solid papillary, or this diagnosis, you basically got full credit. Okay. You didn't get any credit if you didn't say, if you called it benign or something. Okay. But I can go over all that at the end. All right. Last, that is not me, is going to be Lindsay.
Hello.
Hi.
All right. I'm gonna try. I will start with your screen, and then maybe I can switch to mine to show the IHC.
Of course, yeah, whatever you'd like.
All right. So the patient was a 65-year-old female with a gastric body mass, and they did a wedge resection. And the question was, what's your differential and your favorite diagnosis? So here's the gross image. You can see that the mucosa here that's on the bottom looks very normal. And then here's your muscularis propria, and within the wall here, you can see this solid tan white to yellowish lesion, pretty well circumscribed, but not really encapsulated. It looks like it's rising from the wall and not associated with the mucosa. So you're already thinking of a mesenchymal lesion in this case. And when you look at the section provided, there are a few notable findings. So again, it does look pretty well circumscribed. Is the resolution, I can't tell, is it blurry for you guys or not? It's okay.
It's okay.
Okay, it's kind of blurry on my screen. All right, so you can see it's composed of these spindle cells. In some areas, there's kind of a fascicular arrangement, and in some areas, it has a bit more of a whorled appearance. When you look at the cells on higher power, a lot of them appear quite elongated. Some of them have somewhat tapered nuclei. They're pretty bland looking. There's not a lot of mitoses. And the cytoplasm is kind of pale eosinophilic. They don't have very distinct cell borders. Sorry, I'm trying to, oh, there we go. Okay, zooming out, sorry. So obviously, if you get a spindle cell lesion in the stomach, you're going to be thinking of a few different tumors. The most common mesenchymal tumor in the stomach is going to be a gastrointestinal stromal tumor. So that might be on, well, that definitely should be on your differential, and that might have been on the top of your differential. There are a few features here that are a little bit unusual for a GIST, but I don't think you could say that it definitely wasn't a GIST, just based on the morphology. As I said, those very elongated spindle cells with the tapering nuclei are a bit not typical exactly of what you'd see in a GIST. Additionally, there's this lymphoid cuff around the lesion, and as well as some interspersed aggregates of lymphocytes, which is something that is not typical for a GIST and is instead classically described in GI tract schwannomas. So that would also be something on your differential in this case, especially with the appearance of the cells in this tumor. I would generally say you also probably, when you get a mesenchymal lesion in the stomach, another thing to think of is a smooth muscle tumor. Obviously, the morphology in this case isn't quite typical for that either. It's less fascicular, it doesn't have the nice intersecting fascicles. The cytoplasm isn't quite as eosinophilic, and the again, those very elongated nuclei are a little bit unusual, as well as the lymphoid infiltrate, but I would still do a panel that included those entities. So I can show you the immunostains. Oh, let me see. Oh, okay. Thank you. All right. So this was the c-Kit or CD117 immunostain here. And as you can see in the there we go. In the lesional cells, it is definitely negative. You do see a few scattered mast cells here, but the spindle cells are not staining at all. So that's pretty convincing. And typically, a spindle cell GIST in the stomach should have strong CD117 staining, and DOG1 wasn't done in this case, but it should also be negative. And then in contrast, here's the S100 stain. Oops. So, all right, there you go. And you can see that it is strongly staining the tumor cells in this case. So that is consistent with a gastric schwannoma, which is what we suspected based on the histologic features we saw. The smooth muscle tumor stains weren't done in this case because this pretty much cinched the diagnosis, but you could do a Desmond and or an SMA to exclude that diagnosis as well. And just to emphasize that the schwannomas in the GI tract often have a little bit of a different look than schwannomas in other places. They often don't have the Antoni A and B zonation that you would typically see in schwannomas. And additionally, they're not encapsulated, and they often have that lymphoid cuff that you saw in this case. But like in other locations, they're benign. So you do want to make sure you distinguish these lesions from other tumors like GIST that have more of a spectrum of biologic behavior. One other feature I didn't show on the H&E that you could also look for is the kind of random nuclear atypia, which I think you did see some of in that slide. That is pretty typical in schwannomas and less common in a GIST. Any questions? Sorry if it was too easy a case, but we actually just had a string of gastric schwannomas. They're actually pretty rare, but we had several in the last few months. So I just thought I would show one. But yeah, it shouldn't be too difficult to diagnose. So hopefully everyone got that one.
Awesome. Thank you. Yeah, I'll go over if you guys want, I can go over now before you leave what the results were, or I can just finish my two and then go over the results. Questions? Okay, then I'll just do my two and then go over the results, right? I don't think there's anybody else left, right? Okay. So since we're on the topic, let's just move here. 53-year-old man with a right knee mass. What is your differential? What stains would you order? And sort of what's your favorite diagnosis? So the gross image, you know, whenever you say knee, right? Or you always have to say, is it in a knee bone, right? Or is it in the soft tissue around the knee? And I think this is just based on this, pretty apparently would probably be in the soft tissues around the knee. It's very circumscribed, very glistening, sort of yellowish pink, with a little bit of a tail of some tissue here. The one comment I would make is this is a very nice photograph of the external surface before the specimen has been inked. But what was missing in this case was a photograph of the cut section. So I can't really show you the cut section of the tumor. I can only show you the external surface. So just a reminder, please photograph the cut sections as well. So here's a couple sections of the tumor after it's been inked. And again, extremely well circumscribed. And the nuclei are very far spaced. So this is sort of paucicellular to moderate, at most moderately cellular. So not a very hypercellular lesion. The architecture is a little bit vaguely sort of fasciculated, or maybe almost, even if you look very closely, almost sort of whorled, or so-called stauroform, where the fascicles are sort of curved, sort of curvilinear fascicles rather than straight fascicles that sort of intersect with each other, like little, yeah, here's a nice area where it's sort of whorled, short fascicles or whorls, okay? And maybe a little bit more prominent here as well is how the nuclei are quite elongated. In some areas, depending on how they're cut, they're plump, but in other areas, they're very sort of squished and tapered and curvilinear, okay? So curvilinear fascicles, curvilinear tapered nuclei. Hopefully you may be thinking something in the nerve sheath family. And so if you said a nerve sheath tumor, you at least got, partial credit. And so then we have to start thinking, just like with the schwannoma, right? What are the components of the nerves, and what other possibilities might there be? If we're going to focus on a nerve sheath tumor, we want to think about, neurofibromas, right? Which are kind of heterogeneous conglomerates of both Schwann cells, perineurial cells, axons. We want to think about schwannomas, right, which you just saw, which are only Schwann cells. And you want to think about perineuriomas. Don't forget about them. Those are tumors consisting of only the perineurial cells that are the cells surrounding the nerve sheath. And so the histologic features of perineurioma compared to neurofibroma or schwannoma, schwannomas tend to be circumscribed and or encapsulated. Neurofibromas, unless they're plexiform, tend to be a little more diffusely infiltrative or expansile. Perineuriomas also tend to be circumscribed or encapsulated. Perineuriomas, characteristically, on low power, you may think about a neurofibroma because of the pallor, because of the paucicellularity. But what's going to clue you into this diagnosis, which is perineurioma, are these very short whorled stauroform fascicles, okay, and this very monotonous appearance. So perineuriomas can be in various age ranges. They can be small or large, but they very characteristically have this fasciculated whorled stauroform growth, whereas neurofibromas would be more diffuse sheet-like without very significant architecture, and for the most part, and schwannomas would have longer fascicles and or verrucae bodies. So in this case, the immunostains that are positive in perineurial cells would be EMA, CD34, and GLUT1. Stains that would be positive in, schwannomas and Schwann cells, which you just saw, of course, would be S100 and SOX10, which would be completely negative in this tumor. And neurofibromas would have a hybrid of everything. They'd have some cells that were perineural EMA, some cells that were schwannoma S100. So this is a really, really, really classic example of a perineurioma. And I just wanted to emphasize that growth pattern and the immunohistochemistry. Questions? Okay. Yeah, and certainly it would be negative for smooth muscle markers, et cetera. Sorry, I don't have the stains on me for that case. And then the last one is a 35-year-old female with a middle ear mass. What immunostains would aid in your diagnosis, and what is your favorite diagnosis? So, if you believe in statistics, this is a gimme, because this is the most common middle ear mass, the most common middle ear tumor. And so if you basically were just like, well, I'm just going to name what the most common tumor is, you would be right. And so, but I wanted to talk about it because we don't see these very often, and the nomenclature is somewhat challenging. So these generally are very small because the ear is a small space and they don't have a lot of room to maneuver in there. So often it's very cauterized, as you can see, and the cells can be very crushed. So the diagnosis can be hard to make just because of the technical aspects of the procedure that kind of affects the quality of the tissue. However, in areas where the tissue is preserved in the center, we can see that it's, number one, richly vascular with these capillary and a little bit larger size vessels. We can see that the tumor cells themselves are somewhat nested, okay? You can draw sort of lines around these tumor nests. The nuclei are ovoid to elongated with arguably sort of stippled, or maybe one might say salt and pepper chromatin, but I don't know what salt and pepper looks like on a slide, so I'm just going to say sort of stippled. And so the cytoplasm being somewhat, moderately abundant and eosinophilic. Okay. So, putting your knowledge of statistics and your knowledge of morphology together, a nested richly vascular tumor with elongated nuclei and stippled chromatin might make you think of what this diagnosis is, which is a paraganglioma. A middle ear paraganglioma is the most common tumor of the middle ear. So this would have your characteristic chromogranin synaptophysin positivity in the tumor cells, S100 positivity in the sustentacular cells, and it should be keratin essentially negative, or just very, very, very rare or weak cells, but essentially negative. The clinical name for these tumors is glomus tympanicum. There's also a glomus jugulare, which is a paraganglioma of near the jugular vein in the neck. And some of you, the reason I wanted to put this on here was because of the terminology glomus, okay? So, glomus tympanicum and glomus jugulare are a little bit misnomers because these tumors are not glomus tumors in the soft tissue sense of the word. Glomus tumors in soft tissue are perivascular myeloid neoplasms where the tumor cells surround vessels and are positive for myeloid markers like SMA. Here, the tumor cells don't surround vessels, they just kind of clump themselves together, but they are associated with vessels because, of course, what are they doing? They're secreting, into the circulation. So these are not perivascular myeloid neoplasms or true soft tissue glomus tumors. These are middle ear paragangliomas, or so-called misnomer glomus tympanicum. Does that make sense? Okay. Any questions based on that stuff? Okay, then let me get rid of that and bring in.
Did I miss the salivary gland one?
Did I miss something? We had lung transplant, schwannoma.
And you have 3,
Did I? Shoot.
and I thought we only just went over 2, unless I somehow
Yeah,
blanked
you.
an
I think
entire
you had
one.
like
I
a
have
salivary.
3.
Yeah, there. I think it might have been maybe a mucoep that you were going for.
Oh, did I forget to put it in this presentation? No, I
I
didn't. It's right there. I just forgot to. Yep. Okay. Thanks. Did I have 3? I feel like I'm shamefully putting more questions on the exam than anyone else, but when nobody gives you questions, then you sort of just get them from me. Okay. Cool. Thank you for the reminder. Well done. So this was a 25-year-old male with a parotid mass. What's the diagnosis? What's the grade? And what's the defining molecular anomaly? Yes, I mean, I don't even need to go over this because you guys did so well. So yeah, so in the neighborhood, right, we have basically serous acinar cells, so we can confirm, yep, we're in the parotid. We have what appears to be an infiltrative neoplasm that sends its tongues of both mucin and tumor cells out into the surrounding parenchyma and dissects between normal tissue on the left and right. When we look at the cells within the mucoid spaces, we see that they're composed of these very monotonous, arguably relatively bland cells with ovoid nuclei, maybe some intermixed inflammatory cells, but really no pleomorphism or mitoses, but an abundance of mucinous cells with very clear intracytoplasmic mucin. So yep, this was a mucoep, which I think most of you at least mentioned. Grade. So some of you were clever and said it depends what grading system we use. Some of you called it low, some of you called it high. What I want to point out is that, you know, generally, for clinical purposes, assigning a grade of low or high is going to be much more helpful than assigning a grade of intermediate. And so when we look at salivary gland tumors, mucoep specifically, when it has these large cystic spaces full of mucin, those tend to be associated with lower grade tumors. So just the low power appearance should imply potentially low grade because it's very cystic. Secondly, the cells are very bland and monotonous without mitoses or pleomorphism. These are predominantly intermediate cells and mucinous cells. So if you don't see frank squamous elements, that's still fine for the diagnosis. But this is intermediate and mucinous predominant. It's bland, but it's a carcinoma, so it is invasive. So unless you start seeing things like mitoses, pleomorphism, necrosis, PNI, LVI, I would argue that these should still be classified as low grade, which this one is. In this case, there was no PNI, LVI, or necrosis. Rearrangement would be CRTC 1 or 3 with MAML2 gene. So if you said mammal anywhere, you got credit for at least a third of that question. Other, I think things that came into the differential might have been other salivary carcinomas like secretory. But really with this amount of mucocytes, true intra, and in this case, extracytoplasmic mucin, you're really limited in your differential diagnoses. I thought this was a very characteristic mucoep. Questions on that? Okay, thanks for the reminder. I will now share the PowerPoint. All right, you can see that? Okay, yep. So these were this is the summary of the questions, who presented them and what the answers were. So the average scores are listed here. The highest score was just name that organ and diagnosis. So the thymic question did really well. Probably the lowest score here was the lung transplant. I think because many of you, as Dr. Hussein mentioned, misread the question and didn't realize that this was not a native lung. So those of you who realized it was not a native lung, had identified the vascular rejection, but many of you didn't realize it was not a native lung, and you said things like UIP. Everything else sort of did somewhere in between. You can see here, if you, for most cases, if you either favored the correct diagnosis or listed the correct diagnosis first, you got full credit for it. If the correct diagnosis was somewhere in your differential, you got partial credit. And some of these, I graded each part separately. So, a third, a third, and a third, a third, a third, and a third, for example. So, yeah, that was the breakdown. If you want your individual scores, you can please email me and I will give them to you. In this particular exam, we're here, right? So we're 2021-12. This is how our PGY1s, 2s, 3s, and 4s have done over time. So we're sort of right on track with where we are in the past. This was our only real outlier up here. The high score for this exam was an 82. So congrats on that. Yeah, that's about it. Those are just the former exams. So do you guys have questions? Okay. Thanks. Well done.
All right, thanks.
Thank you.